Today we will talk about the Bordetella Pertussis. First of all, we will look at the characteristics of the Bordetella. It is a small gram-negative coccobacilli. It means that it has both coccus and the bacillus properties. Strictly aerobic in nature, non-motile, encapsulated in virulent strain, oxidize amino acid. That is the important thing. Bordetella oxidize amino acid, but it doesn't ferment carbohydrates. Growth requirement it requires is special enriched media like Borde Django agars and the Regan low agars for optimal growth. So these are basically the two important enriched media for the Bordetella. Microscopic features appears as single cells or in clusters, small clusters, but it doesn't form any spores. Stain poorly with gram stain, but can be visualized using immunofluorescent or PCR based detection. So this is the most important thing. Bordetella detect mostly in immunofluorescence or through the PCR. Next, we will look at the pathogenesis. First is the adhesins that helps in the attachment of the Bordetella to the respiratory tract. First is the filamentous heme agglutinin FHA facilitate attachment to respiratory tracts. It's basically mostly affect the respiratory tract. Fimbriae aids in adhesion to the ciliated epithelial cells as our trachea. In the trachea, you will see the presence of the cilia. Pertectin, PRN, contributes to the colonization. So this is the three most important adhesins: filamentous heme agglutinin, FHA, fimbriae, and the pertectin. Next is the toxins. So first one is the pertussis toxin PTX, a major virulence factor that disturbs the immune responses. Adenylate cyclase toxin ACT inhibits phagocytosis and immune cell function. Tracheal cytotoxin TCT damages ciliated respiratory cells. Dermonecrotic toxin contributes to the local tissue damage. So these are the important four toxins produced by the Bordetella pertussis: pertussis toxin, adenylate cyclase toxin, tracheal cytotoxin, and the dermonecrotic toxin. Other factors like oligosaccharides triggers inflammations, and the type 3 secretory systems aids in immune evasion. Next, we will look at the transmission and epidemiology. First one is the mode of transmission. So airborne droplets from the infected individuals enters into the lungs of the healthy person. So this is the how Bordetella transmit from one person to another. Incubation is typically 7 to 10 days, and reservoir is the humans are the only known reservoir for the Bordetella. Epidemiology occurs worldwide with periodic outbreaks in the different regions. It is most common in infants and the young children, but also affects older adults due to waning immunity. So this is the most important. Bordetella infection is most commonly in the infants and the young children. Vaccination has reduced incidence significantly, but waning immunity remains a concern. So this is how Bordetella transmit from one person to another. Next is the clinical manifestation. So it has three distinct stages: catarrhal stages, paroxysmal stage, and the convalescence stage. First one is the catarrhal stage that lasts for 1 to 2 weeks, in which the symptoms will be mild fever, nasal congestion, runny nose, sneezing, and the mild cough. And in that case, this stage is highly contagious. Next is the paroxysmal stage that will last for 2 to 6 weeks. Severe and repeated cough fits, paroxysms, in that case, characteristic whooping sound due to forceful inhalation. So that is the most important features, whooping sound related to the Bordetella. Post-ptosis vomiting after the coughing. That is also the feature of this one. Apnea, especially in the infants. Convalescent stage, weeks to months. Gradual recovery with persistence, dry cough. That is the recovery phase. Suspect to secondary infections. Next, what complications that you can see in Bordetella? First one is the pneumonia, that is the most common. Second is the seizures, encephalopathy due to hypoxia, rib fractures due to violent coughing, and death, especially in the infants. So you just have to remember the three stages: Catarrhal stage, paroxysmal stage, and the convalescent stage. Next, how we will diagnose the Bordetella? Through the PCR, we can detect the genetic material of the Bordetella. Next is the culture. This is gold standard required to most important media, Bordi, Django, and the Reagan law agars. Serology detect the anti-pertussis antibodies, and clinical diagnosis can also be coughing episodes greater than 2 weeks that last for 2 weeks or greater than 2 weeks. Inspiratory woof or post-ptosis vomiting. So this is the clinical diagnosis. Next, treatment. So antibiotic treatment most effective if given in early stage. So first line therapy is the macrolide, azithromycin, clarithromycin, and erythromycin. Alternative therapy is trimethoprim and sulfamethoxazole for macrolide intolerant patients. And along with that, we will give the sportive therapy, oxygen therapy for infants with respiratory distress, hydration and nutrition support, and avoid cough suppressants, ineffective or may prolong the symptoms. So, but the final decision will be made by your local physicians regarding treatment. Prevention. So, most important vaccine is the DTaP. D for diphtheria, T for tetanus, and P for pertussis given to the children. So in this vaccine, you will see the combination of 3-1 diphtheria, tetanus, and the pertussis. Next is the DTaP vaccine booster dose for adolescents and the adults. Vaccine schedule, 5 doses at 4 to 6, 15, and 18 months, and 4 to 6 years. So this is the course of the vaccine regarding DTaP. DTaP booster at the adolescence age of 11 to 12 years and during pregnancy 27 to 36 weeks. Herd immunity and cocooning's strategy, vaccinating pregnant women and close contacts of the newborns. So this is all about the Bordetella pertussis. If you still have any question, you may ask in the comment section. Thank you so much.